Welcome, everyone. My name is Claude Deschamps. I'm president of your medical group. We have an exciting program today for our first medical group town hall on high-value care. I'll start by introducing our speakers. We will start with Dr. John Brumstead, who, of course, is our network CEO, and he will provide an overview about the big why. Why is it so important for us and our patients to continue our journey into high-value care? I will briefly follow him and discuss our recent journey. Then Diana Skelly is our Senior Vice President for high-value care for our network, along with Howard Shapiro, now consultant in population health. We'll discuss our partnership with MVP, which is really the highlight of this town hall. They will be followed by Dr. David Schneider and Dr. Tom Peterson, who are respectively Chief of Cardiology in the Faculty Practice Division and Medical Director of the Cardiovascular Service Line. And Tom is the Chair of the Network Department of Family Medicine, and he is the Medical Director of the Primary Care Service Line. They will really offer their respective perspective on primary care and subspecialty care in the world of value-based care, and what has their involvement looked like so far. We're gonna then have Laurel Kelly, our Director for Communication and Engagement for the medical group, who will cover the marketing plan that is gonna start very soon. And then we'll have a few minutes for questions and exchange with the panel and also our support crew that is there waiting to help with the question. A few housekeeping items. We have a larger audience than usual for our medical group town hall right now. And so we have invited clinical directors across the network, in addition to our physician and advanced provider. So I thank you very much, all of you, for taking part into this important event. All attendees are going to be muted automatically by the host. We will please use the question and answer window to submit question anytime during the hour. And we'll try to do our best to follow and answer those questions either during the hour or later if need be. And there will be some time at the end. If you miss any part of this event, I'd like you to know that this is recorded. Really, it will be, I hope, a very useful experience for all of you and us, your team, who is very involved in value-based care. So we will start with John Brumstead, who is going to give us an overview and his perspective. John.
Thank you very much, Claude. And as Claude said, I'm John Brumstead, CEO of our UVM Health Network. I do want to begin today by expressing gratitude for what each and every one of you do every day. It sure hasn't been easy the past couple of years delivering healthcare anywhere, and particularly here, and it's not easy today. It's well recognized by all of us. So I hope in this wonderful North Country summer, you're all getting time to get away, to rejuvenate and restore. I've done that recently to catch up with family, and so I really know the importance of that. Other presenters today, as Claude said, are gonna go into details on the topic for today, our continued transition to high value care, and specifically our plan to partner with MVP Healthcare to put a Medicare Advantage plan into the market this fall. I want to put our transition and this initiative into a broader context. And to do that, I want to take us back and give a brief history lesson. So bear with me for a couple of minutes here. We started the UVM Health Network a decade ago, October 1 of 2011, as Fletcher Allen Partners. And the goal of that, as it remains today, is to maintain access to high quality healthcare services in our region in a sustainable way, and while meeting the triple aim, which is actually transitioned to the quadruple aim. And since inception, we've really had two core strategies, just two. One is to create a tightly knit integrated delivery system in the catchment area of our academic medical center in Burlington. And because of that, by definition, to have an academic focus for our integrated delivery system, and to shift to a population health focus and to move away from fee-for-service. And that is a shift to high-value care. High-value care can be defined pretty directly as moving to a population-based healthcare model and have that supported by population-based payments. In our previous parlance, that was capitation. And we keep those two core strategies today: integrated delivery system, shift to high-value care. And along the way, we've made unbelievable progress. You know, when we're in the heat of delivering healthcare, sometimes we don't reflect on the progress we've made, but we've started new residency programs in family medicine and emergency medicine. We've brought hospitals in our region together with home health, and we've developed a unified medical group. Believe it or not, and many of you don't, we have actually streamlined our management structures, and we're overseen by a unified governance structure. We've implemented or in the process of implementing standardized workflows supported by IT applications across our network, all to become more of a system of care. You all know about Epic, Workday, Premier Connect, standardized accounting and budgeting systems. And all of this, again, all of this to focus on our transition to high-value care and to create a tightly knit integrated delivery system. So we've accomplished a lot, but there's still a lot to do to meet those strategies. To continue our transition to high-value care, this past late fall, early winter, we engaged McKinsey. I think you all know of McKinsey. They're a national consulting firm, to work with our senior clinical leaders and administrative leaders to get really specific, to chart a path forward towards realizing the strategy of moving to high-value care. And you can talk about strategies all you want, but unless you develop specific tactics and initiatives, you're just not going to get there. So we've worked with McKinsey as a group to define our specific next steps. And to outline those next steps, I'm going to turn this over to Dr. Deschamps, our EVP, Executive Vice President of Clinical Affairs, and President of our medical group, and the other presenters. Again, thanks for your joining and your attention, and I'll certainly be here to answer any questions that come my way at the end. Thanks. To you, Claude.
Thank you, John. Thank you very much. So earlier this year, Dr. Bromstead and I announced the continuation of our journey to high-value care, aligning our reimbursement and care delivery models to improve patient outcomes and control cost. Over the past several months, we have been working, and that's a big we. So many people have worked behind the scenes to better coordinate our high-value care initiative across the network and provide a structure and resources to support these efforts. So there are 4 big rocks. I call them big rocks. First, clinical planning. Align our care delivery to optimize revenue in value-based contract and secure support for care that is tailored to our patients' need. Leveraging new resources to perform in value-based care arrangement. Manage patients in the lowest acuity care setting possible. And expanding access for our high-risk patients by improving coordination and collaboration between primary and specialty care. So first rock is really clinical planning. The second one is what we call the PHSO, Population Health Service Organization. Really, this is a shared service, an assortment of service. PHSO manages, help provide resources and manages those resources to support our providers, staff, and clinics. And that includes, for example, analytics to inform clinical decision-making, identify patient needs, and monitor and improve quality. Care management to integrate and expand resources to proactively manage complex, high risk, and rising risk patients. Documentation support, such an important thing to ease the administrative burden on you, the providers. And finally, change agents to identify and share best practices. That was the second rock. The third rock, alignment with the accountable care organization. Coordinate and streamline the network and One Care Vermont operations to improve performance and reduce cost. We also wanted to actually align the ACO better with the medical group. And through this, actually the medical group has been able to have Dr. Alicia Jacob and Carrie Wolfman play an important role in the ACO in the past year. So the ACO is truly changing and better aligned with the medical group. And finally, value-based contract, the fourth rock, reduce the number of payer contract and performance metrics. Align those contracts to support initiative we believe are important to quality patients, care, and population health. Increase the revenue to our network to enable reinvestment in quality, innovation, and infrastructure. And so important, partner with MVP Healthcare, MVP standing for Mohawk Valley Physician Health Plan, to offer a Medicare Advantage plan. You will hear that in a minute from Diana and Howard. Really, my interpretation of this is that this is an opportunity for us, the provider, to regain a better control on how we will deliver care. A system of support that will help you do your job with much less burden and that will be more resourced. So let's hear about our new partner and what that means. So Diana and Howard, I will turn it to you. Tell us a little more about, or a lot more about this new partnership, please.
Thank you, Claude. Thank you, John. So Diana and I thought that we would take our few minutes of time and just try to have a little chat between the two of us about how we got here and how we got to our relationship with MVP. But thought we would start, Diana, with what is Medicare Advantage? How does that differ from what we traditionally think of as Medicare?
Thanks, Howard. I think it's a pretty basic question, so I think folks on this might know this, but you have options as you turn 65 or older when you age into Medicare. There's the original Medicare that's offered directly from the federal government, and that includes your Part A and Part D, and then you buy some supplemental insurance to cover what's not covered by Part A and Part B, and you also purchase some prescription drug coverage if you so choose. But there is another way to access Medicare as you age in to Medicare, and that's through a Medicare Advantage plan. In these plans, the commercial insurer contracts with the federal government, and that's Part C is what Medicare Advantage is, and it combines Part A and Part B. And the commercial insurer will often offer many other benefits to the purchaser of a Medicare Advantage plan. That may be prescription drug coverage, dental coverage, vision, hearing, et cetera, depending on the plan. So really consumers have a choice of choosing the original Medicare or a Medicare Advantage plan through a commercial insurer. And many of these commercial insurers will have partnerships such as the one that we're developing with MVP. You see these starting to really evolve across the country because of the nature of the Medicare Advantage plan and what CMS is actually asking you to perform on requires a very deep level of partnership with a provider organization or several provider organizations in order to perform on these things, such as the clinical outcomes and patient satisfaction, patient experience. So it's very common to have these types of partnerships with a commercial insurer that we're developing. So with that, Howard, I think I'm going to turn it back to you and just give us a little bit of the history of how we got here with our partnership with MVP.
Sure, and I think Dr. Brumsted stole much of my thunder here, but in the way that I think about it is that as John went back to 2011, I'll start in 2012 when John was talking about this move from moving our network from a fee-for-service net patient revenue organization to one that would desire to take a single payment to care for the populations that we serve, and to try to get to as close to 100%, or as I think we jokingly said, John would ask us to get to 120% of our revenue. Of course, we'll never completely get away from fee-for-service, but it's our desire to move down this path. And again, as John mentioned, we made a number of investments. John mentioned some of them. I would then also like to mention, our investments in our ACOs, our investments in our data management office, our relationship with our collaborative partner in New York State, Hudson Headwaters, and most importantly, over this more recent period of time, the past 2 or 3 years, medical group leadership underwent an educational process to learn about how one does perform best in class in value-based, risk-based environments to achieve our goals. The other thing that was produced and is available to anyone who wants to see it is the Road Ahead document, which lays out our strategy for our network to perform in value-based care. Last year, through a consulting relationship with McKinsey, a decision was made to partner with an insurance company as opposed to becoming an insurance company, and to introduce a co-branded Medicare Advantage product into the market. The product is just one part, and I want to emphasize this, it's just one part of a larger revenue strategy in a value-based care environment. And in the late fall of last year, an RFP was issued by the network for an insurance partner. And I was hoping, Diana, you could talk a little bit more about that RFP and how we ultimately chose MVP.
Thank you, Howard. So what we did with the selection process is really work through our high value care council, our governance structure for the network. We have a high value care council that reports to a strategic management council, and we worked with the high value care council under Dr. Deschamps' leadership on developing a set of guiding principles that the insurer really needed to respond to in that RFP. And those guiding principles are available to anyone who would like to look at them, but they included things like, are they a not-for-profit like us? Are they already operating in New York and Vermont? Do they have experience with academic medical centers? Are they willing to invest substantial amounts of cash into a transformation and ultimately a successful Medicare Advantage plan? And are they willing to really have a graduated partnership with us so that we can build capabilities to perform in Medicare Advantage over a period of time to be successful with our clinical folks. And I think one of the most important guiding principles was cultural alignment, especially our clinical culture alignment, which I know that Tom Peterson and Dave Schneider will speak to a little bit. Cultural alignment in terms of, is the payer really willing to come together in a new and different way than ever before in Vermont and upstate New York to offer a plan that truly is clinically driven and gets us out of the old type of payer partner relationship where we're negotiating fee for service and into an environment where we're really talking about how do we make investments in population health. MVP was one of 9 respondents. We had some really awesome respondents to the RFP, a lot of interest by insurers. And MVP really came out as in the forefront. They were way ahead of the pack in terms of that willingness to really come together in a new and different way. And I think we'll certainly benefit from that. So we did go through a process of whittling down from 9 to, I think we had 4, and then we did a lot of interviewing with clinical and administrative folks, and then we went to 3 and 2, and then finally 1, our MVP partner. So that's certainly how we got to this point. We now have a master affiliation agreement with MVP that is a very long-term agreement with some substantial promises for investment in this particular product and the capabilities. So I'm going to turn it over to Howard for the most popular question we get about this relationship. It comes up at almost every meeting we have. Is this all about money? Is really the question that we get very often. And I'm going to turn it over to Howard, and I know he'll kick it over to our clinical folks, which will help answer this question as well.
Yeah, so from the get-go, I just wanted to admit that finances do play a part, but the reality is that this relationship gives us an opportunity to work with an insurance company to co-invest and design an experience and encounter a product that we will be proud to participate in. And in choosing MVP, as Diana said, we firmly felt that they had the cultural partnership to build the product like that. And to prove some of that is that, MVP has done deep research in an attempt to understand what their members, our patients, want from an insurance company. And now they are starting the same research goal to understand what you, our physicians and providers, want from an insurance company. And they'll meld the two of those together to make some recommendations as we co-build this product. The goal, as it has always been, is to improve the lives of the populations we serve while assuring financial sustainability to reinvest in our people and our facilities. So yes, to some degree, it is about finances, but the reality is to co-develop a product that we can be proud of in how we care for our patients. So with that, I thought I'd turn it back to you for introductions of the next group of folks.
Before we go with Tom and David, I'd like maybe you to cover briefly why we have been under some restriction in what we can say about this arrangement, about this relationship before October 1st. What are the reasons?
Diana, do you want to take it?
Sure, I'm happy to answer that. So as we talked about before, these Medicare Advantage products are offered by commercial insurers who contract with the federal government. And in our case, have an agreement now to put a co-branded product in the market. since they're a commercial insurer, they're competing with other commercial insurers, and CMS has very strict guidelines on when we're allowed to talk about these things broadly within the organization, and also to the external environment. And the reason for that is the competitive environment. They really try to level the playing field for the commercial insurers and make sure that one is not out ahead of the other in terms of marketing their plans, because it is a competitive environment and people have choice. And CMS, again, really wants to level that playing field. So you all see the commercials. They start usually in October. And you'll be hearing more about that when we're allowed to communicate everything. Does that help?
Thank you.
Yep.
Yes, Diana, thank you so much. All right, we'll now go to Tom and David. Tom, please tell us about how we have and will continue to influence the benefit package, please.
Sure. Good afternoon, everyone. It really has been an interesting experience and a pleasure, actually, to interact with the MVP colleagues around a shared Medicare Advantage plan regarding like the plan benefits, the patient experience, and the experience of the clinical team. And these conversations have included many members of their team, their medical directors, the benefit plan managers, their data gurus, customer research group, information technology, pharmacy, care management, and they actually do have an innovation team, which has been quite fun. You know, this started as a crawl, but I think our pace is very quickly picked up. So it's actually a pretty fast dance at this point. And I think we've quickly found a great deal of common ground. And I'll just say, those include, as mentioned, better care and outcomes for our shared population and their members, including attention to those with rising risk. We want to limit risk and improve health. The second is providing a better experience for patients and members and allowing them to optimize their use of their benefits plan. And then the third, you know, from our view, is providing a better experience for providers and other healthcare stakeholders, for example, to limit unnecessary administrative oversight, pre-authorization, to make the best use of provider decision-making. And we also found a commitment to innovate using a framework of data and usage patterns and technology. And then the fourth one is also equally important, is our attentiveness and commitment to understand and to resolve health inequities. So we pretty quickly found ourselves working on aligning projects and activities that are in motion already in both organizations, and then prioritizing these based on data and risk. And so those areas include diabetes, heart failure, mental health, elder care, among others. But those very quickly was common ground for us. And we do meet weekly and have a number of conversations. I just want to touch base on a few of those so you can get a flavor for how invested they are in working with us in this evolving partnership. So we've done a comprehensive benefits review, and they've been very interested in our suggestions around benefit modification. We've talked about 7-day support from MVP, and again, about limiting unnecessary administrative and pre-authorization and approval sorts of things. Really, a key question that's come up is, how can we work together as partners in care in the same medical neighborhood? So a completely different relationship than a typical fee-for-service arrangement. Data sharing where appropriate, whether it's our quality data or reviewing their consumer survey data and preferences and utilization patterns. Provider stakeholder groups, focus groups, and discussion with our content experts already. An interest in investing in equipment to assist with chronic disease management, exploration of home care, whether that's home-based labs or a mobile van or other strategies. Obviously, development and enhancement of virtual care providers, care managers, benefit managers, pharmacists, actually understanding their pharmacy and formulary, asking us, well, what things make sense that for patients, how to code to facilitate efficiency and accuracy. And then they've been very interested in aligning with our PHSO development to improve efficiency and ease of access. So Claude, I'll stop there. Be glad to take any questions now or at the end.
I think we will go for at the end or a little bit later, Tom, but thank you so much. I'll turn to David Schneider. David, although our influence was limited this year due to timing, I know you were very involved in early conversations about given your role in subspecialty care. Can you tell us about your involvement as you worked with MVP in those negotiations?
Well, thanks for inviting me. I guess I would view myself as the end organ user among the people who have spoken today. So heart failure is a big draw on resources. Rehospitalization for heart failure is a focus across the country. And as Tom mentioned, that's been a point that was brought out by him as well as by our MVP in terms of a focus. How do we provide better care for them? Probably the best way I can describe the interaction so far is that we've been actually working within the cardiovascular service line at trying to pull together a multidisciplinary group to provide comprehensive heart failure care across the entire network. When I went to my first meeting with the folks from MVP, I saw immediately a dovetailing of their interests and our interests. Found very open, collaborative conversations. The first point of discussion was, can we offer the right medications to the patients? And the great news these days is that we can offer great care to patients with heart failure with generic medications, but there are some newer medications that are not generic, and there was active dialogue about how we can move that into the portfolio so we can get these patients treated. The other issue that's been a real keen focus of our group has been the transition of care from hospitalization to home, and how do we keep those patients home? And there was clear resources being brought to bear, home resources such as advanced care to the patients, discussions about how do we get early home visits. These are the kind of things that have been shown in the literature to improve the transition and actually candidly reduce hospitalization. And that's really, from our perspective, sort of inside the tent, is how do we take better care of our patients with heart failure so that they don't get admitted to the hospital, making sure they get evidence-based care, really being on top of how they're being treated. And I feel that we've found a good partner that will help us to do this in increasingly better ways. So I've been very pleased with our early interactions, looking forward to continuing to build a collaborative relationship. It's a kind of a whole new world, candidly, from my perspective. That's not what I've been experienced with in the past. So I'm excited about the next steps.
Thank you so much, David. And so I'd like to remind the audience that we have a Q&A box that you can use to ask your question. I picked up a question from the chat room, and I will bring that question up at the time of the question period in a few minutes. I will now turn it to Laurel Kelly, our Communication and Engagement Director for the medical group, will tell us a little bit about the marketing plan. Laurel, thank you.
Thank you. Thank you, Dr. Deschamps. So there is quite a lot of work that goes into building a brand and positioning around a new product in the market, and we're very excited about that. And I want to talk a little bit about sort of the work that goes into that and reveal our name and positioning statement and some of the creative assets that you'll see beginning next week. So Ryan, if you could just pull up the slides, that would be lovely. So before I get started, I do want to remind everyone that at this moment in time, all of this information is confidential. Again, Diana talked a little bit about the CMS guidelines that we're under that govern what we can and can't say. So the name of the product is actually confidential until Monday when we begin our Prime the Market campaign. We can't talk at all about the benefits during that marketing campaign that will run until October 1st. But when that campaign, the October one, it's called an open enrollment period. Once that begins, we'll be able to provide more information about the benefits details. And we realize that there's not a lot of time between now and when the product launches on Monday, but again, we are under strict guidelines not to share this too broadly in advance of the deadline. So next slide, please. So again, there's a lot that goes into a brand and we want this brand to build on our UVM Health Network and MVP, but we also want to set this product apart from anything that either of us has done before. So next slide. So when two companies come together, there's a broad spectrum on which they can build the brand. White label means that it will not look anything like either company. It'll look completely different and you wouldn't recognize the two founding companies. Co-branding means bringing two names together, and creating a new brand is similar to the white label where you come up with a whole new name and build a new brand around it. So there is, again, quite the spectrum. And even within the Medicare Advantage market, we see examples that run the gamut on this spectrum. So we really didn't have a specific set of guidelines to follow, but we knew that we wanted to capture the key advantages of this product to the best of our ability and sort of understand or help folks understand kind of what the driving force was behind the brand. So next slide, please. So the name of the product we came up with was UVM Health Advantage. And the reason we did this is to really ensure that the UVM Health name is a recognizable part of this product. Since MVP is the actual insurer, their name will always be associated with the product. So we wanted to be sure, again, that UVM Health is in the product name. We will leverage our brand colors. You can see a few of them up there on the screen. And then you'll see also an example of how the listing appears on Medicare.gov with the name of the product that includes our name and then MVP Healthcare just below. So most often on these insurance product listing sites, this is how the name will appear. So again, securing our name as part of the product makes sure that we are always represented there. And then we've also taken the liberty of shortening UVM Health Network to UVM Health when we combine the two logos together. This is called a logo lockup, and it can get very cumbersome when you have multiple words and design elements in two logos. So shortening this a little bit makes it a little easier to say, a little easier to render on different materials, and is sort of a nod in the direction of the ongoing sort of coming together, uniting of our network. And next slide, please. So for the positioning statement, we can actually continue to the next slide. The positioning statement is really the basis of a marketing story, and we wanted to answer the question of what's in it for me for multiple audiences. And since we want to absolutely answer that question accurately, there's quite a bit of research and data that went behind our positioning statement. So in addition to national Medicare consumer research, MVP actually surveyed thousands of consumers about what they want in a Medicare Advantage product. Over 1,000 of those survey respondents were from our communities, from Northern New York and Vermont. And we took the learnings from that survey to influence the benefit design, and it also helped to inform our positioning statement. There were lots of discussions back and forth between our marketing and communications teams, input from our physician leadership, some of our patients, and the MVP Member Advisory Council. Next slide, please. So for prospective members, we really want them, including our patients. It's it's a bigger audience than just our patients. There are Medicare eligible folks in our communities that aren't necessarily our patients. We want to reach them as well. So any prospective member, whether our patient or not, we want to make sure that they understand that through this product, they'll get care that's built around their needs and their best interests. We want them to have the confidence to take on their personal health goals and challenges and live their best lives with the help of the UVM Health Advantage product. For our own providers and staff, we want our team to know that we can provide the best possible care for our patients through the UVM Health Advantage plan because we're playing an active role in the plan and benefit design. Brokers and advisors are critical audiences in helping prospective members choose the right product. So we want brokers and advisors to be able to recommend the UVM Health Advantage product confidently. And then in the general community, we want folks to feel positive about healthcare that exists in their community, knowing that there's a new Medicare choice that's driven by our expertise and tailored to the folks in our region. Next slide, please. So the positioning statement we arrived at is introducing UVM Health Advantage, created with you, guided by doctors. So as Tom Peterson and David Schneider pointed out, we've been very involved in planning the benefits design. We had some influence over the 2022 product, and we'll have more engagement as time goes on to really design a benefits package and a product, as Howard said, that we are proud to stand behind. So that's the guided by doctors. And then created with you is a nod to the extensive research that MVP did with their own consumers and leveraging national data about Medicare Advantage products to really design a product with the needs of our prospective members in mind. Next slide, please. So obviously, any marketing campaign has an objective, and I will walk through a few of those now. So next slide, please. So first and foremost, we recognize that our prospective members, our patients, have a choice. We are not the only Medicare Advantage product in the market. As Diana pointed out, there's some competition out there, growing competition, and more people choose Medicare Advantage over original or supplemental Medicare each year. So we want this marketing campaign to pique their interest and inspire them to enroll and choose our product. We will focus fairly heavily on our patients, leveraging the trust that we've already built with our patients in the community, and we will market directly to them. We will work to migrate existing MVP Medicare members over to this new product. And then we also want to market to all prospects in our counties, so folks who are switching from Medicare Original to a new Medicare Advantage plan, or switching between plans, and folks who are aging into the market. So the rest of the bullets on this slide just go through the different marketing campaign periods. I talked a little bit about the Prime the Market campaign, which will run beginning Monday the 23rd through September and even a little bit into October. And this really is going to lean heavily on that positioning statement. We want to build buzz in the market, pique folks' interest about what this plan can do. But we are not, again, under CMS regulations, allowed to talk about the benefits in any way. So we've got to really hope that created with you and guided by doctors piques folks' interests. But beginning on 10/1 or shortly thereafter, we are able to send out benefits kits. MVP will have a landing page up and ready by Monday where folks can sign up to receive one when they begin distribution in early October. So that's it in a nutshell, except for I will remind folks that the individual enrollment period runs year round, and that's for folks who age in to the market. And so we will have a marketing presence all year long. And next slide, please. for those of you who love a Gantt chart, I couldn't uninclude this slide. It just lays out the timeline of those various marketing periods. And next slide, please. So beginning on the 23rd, which is Monday, we will be running television ads, radio ads, print and digital ads that again will lean heavily on the created with you, guided by doctors positioning statement. But I did want to show you a few of these assets so you could see kind of what the look and feel looks like. And I'll let everyone know that we will also be placing on-site signage beginning at the end of September, including pull-up banners and smaller tabletop signs. And we will have patient takeaways coming soon to a desk near you. So just so you get a sense of what those looks like, we will demonstrate right here. So next slide, please. This is an example of a pull-up banner. It's very short. There's not much else other than our fantastic product name, our beautiful combined logo, and our positioning statement, and then a web address where they can go sign up for that kit. Next slide, please. And this is what it would look like in an elevator lobby, so you can get a sense of the size and scale. And next slide, please. This is an example of a direct mail piece. It's a trifold that will be mailed out to all prospective members, Medicare eligible residents of Northern New York and Vermont in the coming weeks. And if you'll scroll to the next slide, please. This is what the inside of that mailer looks like. So again, not a lot of copy here. There's not much we can say other than talking about the benefits of the partnership that makes this product possible, and always driving folks back to the web address or a phone number to request a benefits kit. And next slide, please. So to make sure that we can answer questions, because we're certain we'll get questions of our patients when they start hearing about our new product on television, radio, read it in their favorite newspaper, and eventually see the signs in our hallways. So to support you, we have several things coming up this week. Next slide, please. Our objectives with our materials are to make sure that we are all informed when speaking with patients about the Medicare Advantage plan. We want to make sure everybody understands that this is a new product in the market. And then because there's not a lot we can say about it right now, we want to make sure that we know how to refer patients for more information. There are, again, CMS rules that regulate when and where we can talk about the product. We're not allowed to sell in clinical delivery areas. This means that when you're seeing a patient in an exam room, you don't need to talk about it unless they ask you a question. As a matter of fact, you're not allowed to bring it up unless your patient asks you a question, and then you're free to answer the question. But we are restricted on selling in clinical delivery areas. We have been presenting at leader meetings to make sure everybody understands what the product is about. There are messages from Dr. Deschamps. There was one prior to this town hall. There will be one later this week with the recording of the town hall. There is today. We are providing you some information. And by the end of this week, we will have talking points, scripts, and frequently asked questions in an inbox near you. And we are working to get patient takeaways ready for front desks and whatnot, so that you don't have to memorize the phone number or the web address. You can say, please take a card at the desk on your way out, and that will tell you how to get more information. And that is all for me. Thank you, Dr. Deschamps.
Thank you, Laurel. Fantastic. That's very, very exciting. I'm going to go directly to the question. And I have an amazing team to help, along with the panelists, Chris Dillon, Brad Crumpf, Chung Wan, Greg Carlo, Christine Wernicke are available to help us, along with Christina DeGraff Murphy. All right. The first question was in the chat, and it's really about the concern about a recent behavior from the insurer that are not reimbursing telemedicine. And is that a sign, a harbinger sign that they are not going to want to invest in the social determinant of health. So Diana, would you like to take, Diana or anybody, we'll start with Diana. What is our leverage for in our negotiation for our partners to invest in determinant of health?
Well, I think a lot of these questions in the chat, I'm watching them come up, are so related. Things that aren't being paid for, or these discussions that we're having with the insurers about what's right. And I think it's a twofold question. First of all, it's that time of year again where we have to renegotiate our fee-for-service contracts, and these things need to come to the forefront as to what needs to be in those types of contracts. And we do have these discussions with our payers. Telemedicine will be on the forefront of those discussions. It's very important that we keep that going. And we will be having those discussions. But I do want to go back to, again, this Medicare Advantage plan that we're co-branding with MVP and the relationship sort of moving forward. The idea here is that, you were saying guided by doctors, but we really want to come together with MVP, especially around this product and potentially others that we might put in the market, to really co-create something together that makes sense for our patients. A great example is how do we want to care for the newly diagnosed diabetic patient? How do we want to care? I see Roger Knackle put a piece in the chart, a question in the chart. How do we want to care for folks that are leaving rehab and need a wheelchair? This should be a discussion about, what is the cost benefit of this? What is the benefit for the patient? What is the benefit for the health system? And really work on that together. And we're finding more and more, as the physicians have said, that MVP is really willing to come together with us to help design a benefit that works to not only reduce the total cost of care, but have a good patient experience. CHF, as Dr. Schneider talked about, what is the right thing to do for patients to keep them out of the hospital, or a newly diagnosed CHF patient. We should be coming together and talking about that. Not all insurers are in that space. We found that MVP is certainly in that space. And so we want to continue that relationship and move that dial forward. And I hope that answers a piece of the question.
Thank you, Diana. Howard, I'm going to ask you to answer the next question. If you know the number, what proportion of our network patients will be served by MVP? What do you anticipate is that number?
It is small. How's that?
Yeah, well, yes, it's good, but if you can give a number, that'd be even better.
Well, currently there are, I think the number is right, and somebody can correct me if I'm wrong. There's about 4,000 patients that MVP serves in our market in their Medicare Advantage product. We would hope to convert some of those people who are currently not on the co-branded product to the co-branded product. And depending upon how Laurel does in her marketing campaign, we would certainly love to see several thousand more folks sign up for this product in the next year, with the hopes of growing that to a 5-figure number over the next couple of years. But this is a very competitive market, and we hope to have a very competitive product. And I'll throw a lifeline out to Diana or Christina. Did I get those numbers close to correct?
Yeah, Howard, that's good. I will just add that from a market share perspective, if we look at Vermont and upstate New York, United clearly has the majority of the market share in Medicare Advantage, but MVP is second in line. So they do have a good presence, well known in the commercial space, and we're hoping if we really do well in creating a great patient experience, that the Medicare Advantage product will continue to grow in the market as our co-branded product. But it comes down to creating a patient experience together that none other Medicare Advantage product will have in the market.
Thank you, Diana. Christina, do you want to add anything to that answer?
I do not. Thank you.
Okay, good. Thank you. Peter, Dr. Bingham, Peter asked, what are the best opportunities and innovation for preventive healthcare that can decrease healthcare costs for the next 5-10 year horizon in our network? I'll start with Chris Dillon, who is part of our supporting team, but others are welcome to chime in. Chris, would you like to give this your first shot?
Sure. Yeah, I'm happy to take a first shot. And I don't think that we have, a specific set of opportunities or innovations identified other than to say, more generally that, part of what we're doing with the PHSO is to build, an analytic infrastructure to help us identify patients who are at risk, who are at rising risk for getting into, some of these chronic conditions that Dr. Peterson and Dr. Schneider described. So our goal is going to be, to engage with these patients early and often and find, consensus-based therapies, et cetera, to keep them in the lowest risk tier possible to prevent their chronic conditions from exacerbating. So that's a big piece of what we're looking to do broadly with this high-value care work that we're, looking to have supported by MVP, but really apply to all of our patients across the board.
Thank you, Chris. Anybody would like to add to that answer?
Chris, I'll just say, add to that, that MVP is really interested in having a partner who will maintain an active relationship with each and every patient and the communities that we serve, and whether that's a data arrangement or a virtual arrangement or on a manageable panel size with access or access that is facilitated by looking at ways to improve transportation or nutrition. Those things are all on their minds, and I would say those are all levers to be able to build that relationship, which really is sort of the secret sauce to good patient care.
Thank you, Tom. Diana, you picked up on the last question, the question Dr. Nekal asked about equipment. The difficulty in getting timely equipment will, he's concerned, he lived managed care before, that this will increase the length of stay. And is there promise there that we will have a streamlined process to obtain equipment for our patients? Diana or Howard?
Well, first of all, Dr. Neckel, I do want to talk to you about this because I want to know where we're having some challenges so that we can start to work on that together. The other thing is, I think absolutely with our co-branded Medicare Advantage product, as Tom Peterson and others have alluded to, we're really trying to come together and understand the best experience for the patient, the best thing for the health system in terms of cost, the best thing for the providers. How do we come together and provide these things in a decision-making process that's together, not just the insurance company making the decision. So, but I will reach out to you on this challenge because I would like to hear more and why.
Very good.
And I would just real quickly, Claude, and Nate Arch reminded me that, we early on established a great relationship with MVP over pharmacy, pharmaceuticals, and their willingness to put a couple of members of our staff on their pharmacy and therapeutics committee, which is just an important first step in how we care for our patients.
Very good. Well, it's 1 o'clock and it has been a great effort at communicating on our value-based care journey and where we are today. What I commit to with Laurel is we'll pick up all the questions that were not answered and we will answer them in our follow-up communication. I thank all the panelists, the support team behind all of us, and the audience for sticking until the end and asking so great questions. So thank you all for what you do. We'll see you at the next time. Bye-bye.